Well, good morning, everyone, and thank you for joining this morning for Winship Grant Rounds. As a reminder, if you're an Emory University or healthcare employee and would like to receive a CME credit for attending this talk, the login information can be found in the chat feature on the bottom of the screen. If you have any issues with this webinar or the CME, please email Julie or drop a note via the chat feature. This morning, we're very excited to welcome Dr. Faye Johnson. Dr. Johnson received her bachelor's degree from Johns Hopkins, her MD and PhD from the University of Texas School of Biomedical Sciences at Houston. She completed her residency following this at Baylor and her fellowship at MD Anderson, where she is now associate professor in the Department of Thoracic and Head and Neck Oncology. Her research is really multifaceted. Among her lab focus has been identifying mechanisms of resistance to PLK1, SRC, PI3 kinase pathways. This work was translated to clinical applications using SRC inhibitors and others. Additionally, her lab was the first to establish the therapeutic vulnerability of Notch1 mutant head and neck cancer to PI3 kinase mTOR inhibitors, which is currently also, there are efforts to evaluate this in a clinical trial as well. She also has investigated the role of Aurora Kinase in HRE positive cancer, but I would rather she tells you all about all this nice work. Suffice it to say that Faye has been a leader in translational head and neck research, and her work is on the cutting edge for discovery of novel strategies to treat this disease. We are very excited to have her join us today and look forward to her talk. Faye, we extend to you a virtual welcome, unfortunately, to Atlanta, and hope the next visit will be in person. Look forward to hearing your talk. Thank you.
All right, thank you for that excellent introduction, Nabil, and the invitation to talk. I do regret that I can't physically come to Atlanta. I love this city, been there many times. And today I'm going to talk to you about head and neck cancers and some of the recent and upcoming progress in our field. But in order to talk about that progress, I have to kind of put this into perspective and let you know that when I'm talking about head and neck cancers today, I'm going to talk about head and neck squamous cell cancers. There certainly are many other head and neck cancers, but I'll just limit it to head and neck squamous cell carcinoma. These are squamous cancers of the mucosal epithelium. They're still classified by anatomy, and a simplified version of the anatomy is on the right side of the slide. Etiology is diverse, but the vast majority of what we see in the US is either due to tobacco or HPV. Throughout the world, other carcinogens such as betel nut and other viruses such as EBV also lead to head and neck cancer. We do see rare cases of DNA repair syndromes like Fanconi's that contribute, and of course, patients who are immunodeficient have higher rates of many cancers, including head and neck. So if we look at the schema for how we treat head and neck cancer, it will look familiar because I think a lot of solid tumors have something similar. In the early stage disease, we treat with often single modality treatment, surgery or radiotherapy. And then for our patients who are locally advanced, they get some combination of surgery, radiation, and chemotherapy, depending largely on the location of the tumor and the stage. And then those who have metastatic recurrent disease are treated with chemotherapy and or immunotherapy. And with the exception of the addition of immunotherapy in the past few years, this schema really hasn't changed in decades. And you'll notice that there's no precision medicine in our standard of care yet, although it is coming soon. So learning objectives, to recognize the opportunities for precision medicine in treating head and neck squamous cell carcinoma, and to understand the diverse genomic landscape of head and neck squamous cell carcinoma. So a big portion of what we see is oropharynx cancer driven by human papillomavirus. HPV is a double-stranded DNA virus, and there are over 200 strains, but only about a dozen of those can cause cancer. And in oropharynx cancer, that's predominantly HPV-16. Unlike cervical cancer, which was the other common cancer caused by HPV, we don't see very much HPV-18 in oropharynx cancer. And then there are a smattering of other types as shown on the slide. Mucosal HPV is responsible for a spectrum of human disease, from warts to invasive cancer. The majority of cases, the viral DNA is integrated into the host DNA, but not always. HPV infections are very, very common. Over 80% of Americans have had an HPV infection by the time they hit their 40s. Luckily, most of us clear those infections. We don't even know that we had them. They're asymptomatic, and they don't cause cancer, but in a few people, the virus persists and does cause cancer. And the way that it causes cancer, the canonical pathway is through the viral oncoproteins E6 and E7, and you can see the pathways there on the right side of the slide. So E6 leads to a degradation of tumor suppressor P53, and then E7 leads to a degradation of the tumor suppressor RB. As I said, those are the canonical pathways. There are other ways that these oncoproteins can contribute to cancer progression, and that's by interacting with other DNA repair proteins like the BRCA proteins. HPV-driven cancers, HPV-driven oropharynx cancer has really been an epidemic in the United States and in the first world for the past couple of decades. These are very recent data published in 2019, and you can see that the rates of oropharynx cancer, particularly in Caucasian men, is just skyrocketing. And although our typical patient is a 50-ish-year-old white guy, we are seeing older and older patients now, and actually data from this manuscript supports that observation in the clinic. So HPV positive and negative cancers are different cancers. They're driven by different etiologies, and they are distinct. And HPV-driven cancer patients, they do better. These are old data, but they, we still see these numbers. So people with HPV-positive oropharynx cancer, overall survival on the left, we're able to cure about 80% of those people, and then HPV-negative only about half, and then progression-free survival is shown on the right. So these patients do better, and not surprisingly, HPV cancer is molecularly distinct if we look at mutations. So these are the TCGA data that were published about 6 years ago, with a relatively small cohort of HPV positive patients on the right and the HPV negative patients on the left. And you can see things like P53 mutations here, very uncommon in HPV-driven disease, and not surprising because you have the oncoproteins already degrading the P53. Another big difference is the rate of PIK3CA mutations, which is a lot higher in the HPV positive than in the HPV negative. Another publication which had a much larger cohort of HPV positive patients came out about 2 years ago, published in Genome Research, and this paper actually reiterates a lot of what is seen in TCGA. And so the rates of mutations that are common in HPV positive are shown in A, and then HPV negative in B. You can see that the rates of mutation are generally quite different between the two cancers. Again, finding that P53 mutations, for example, are very uncommon in the HPV-driven cancers, but incredibly common, 80% of HPV negative. The majority of these mutations are not targetable. Most of these are loss of tumor suppressor rather than gain of oncogene. A couple exceptions here are HRAS, and this is exciting because there are trials published and trials ongoing with the farnesyl transferase inhibitor tipifarnib, and the initial trials look quite promising, and we fully expect that the ongoing trials will reiterate that, and that at some point in the very near future, we actually will have a biomarker-driven targeted therapy for head and neck cancer. Unfortunately, these HRAS mutations are not very common, only occurring in about 10% of the HPV-negative patients. The other oncogene that's common is PIK3CA, but as you may know, many trials have failed to show much of a response rate for PI3 kinase inhibitors in the PIK3CA mutant tumors, and that's true in head and neck cancer as well. these are data, additional data from that paper, and I know it's a very busy slide, but I put it here just to remind you that if this is an area of interest, that this paper actually does have a mountain of data available. But again, you can see a plethora of largely tumor suppressor genes, predominantly HPV-16-driven cancer for oropharynx. When the DNA, the HPV DNA integrates, it does so in kind of this elegant and interesting way. These data showed a looping model of how the DNA integrates, and because of this complex integration pattern, there are focal amplifications and rearrangements. This group, led by Keiko Akagi and Maura Gillison, actually has additional data that is not quite published yet, and so they wouldn't let me share it, but do keep your eyes open for this because they have expanded on this model. So targeted therapy, there have been many failed trials of targeted therapy in head and neck cancer, and it's not quite dead yet. Obviously, it's a challenge because of the predominant tumor suppressors. So the approach that we took in my lab was to look at drug sensitivity in vitro in cell lines. And you might be thinking, gosh, Faye, you know, cell lines, that's pretty 1990s of you. But in fact, we know these are data I just pulled from publicly available sources, the GDSC and CCLE. You can pull the data yourself. And I pulled these two examples, and these are each data point is a cell line, and it's looking at drug sensitivity on the left, comparing BRAF mutants to wild type for a BRAF inhibitor, and on the right, comparing EGFR inhibitors to wild type for an EGFR inhibitor. And so you can see that the findings that in vitro with cell lines do reiterate what we see in the clinic, and of course, BRAF inhibitors and EGFR inhibitors are FDA-approved, validated drugs for BRAF mutant melanoma and EGFR mutant lung cancer, respectively. So we thought that this approach was valid, and we proceeded with a high throughput drug screen in HPV negative and HPV positive cells. Pretty standard setup. So the cells are plated, counted, and then treated for 72 hours with concentrations that ranged from 0 to 3.16 micromolar, so relatively low concentrations. And then we looked at 16 HPV positive and 17 HPV negative cell lines. And the cells are actually stained at the end with DAPI and counted. And then in our analysis, we looked not just at changes in proliferation, but cell death. And the way that we do that is to create the growth curve, and then to measure this area here, which is called the area over the curve lethal dose, or AOC-LD. And if you have a drug that just leads to a decrease in proliferation, then this growth curve will never go below this 0 line, because that's the baseline of where you started. So if you just have a decrease in proliferation, this AOC-LD value will be 0. And if you get any degree of cell death, then this AOC-LD value will be greater than 0. So we used an AOC-LD value of greater than 0 to indicate cell death and sensitivity to the drugs. So this is an overview on the right of the 864 drugs divided into families. And then we divided those drugs in those families into effective and ineffective. And the way that we defined effective was that if a drug caused cell death in even one cell line, we call that potentially effective. And with that, what I would call a relatively low bar for efficacy, we actually found that half of the drugs in our drug screen were completely ineffective, meaning they didn't cause any cell death in any of the cell lines, and then about half were effective. And you can see that different classes of drugs have different levels of efficacy. So drugs that you're quite familiar with, such as chemotherapy, taxanes, are really quite effective. and then drugs that you wouldn't expect to have much efficacy, like steroid receptor agonists and antagonists, weren't effective. Now, of course, there are some limitations to this screen. You'll see that PARP inhibitors are very ineffective, but those who work with PARP inhibitors know that you really do need to treat cells for 5 days rather than 3. So we may have kind of chucked them in an ineffective bin in this drug screen prematurely. But again, there are limitations with any drug screen that you do. So we then asked the question, did any of these drugs have a differential effect based on HPV status? And so this table actually, when there's a drug listed on the left, it means there was a differential effect based on HPV status, and when it was on the right, there isn't. This is based on p-values. What was really few very striking findings here. First, the vast majority of drugs didn't have any difference based on HPV status. Very few of those drugs did have a difference, and the only family of drugs that consistently had a difference were Aurora Kinase Inhibitors. And in fact, all 16 of the Aurora Kinase Inhibitors that we tested did have a trend for more efficacy in the HPV positive versus negative, although only 7 met our cutoff for statistical significance. There were 3 other drugs in our drug screen that were not Aurora Kinase Inhibitors, but also had an off-target effect of hitting the Aurora Kinases. And interestingly, those drugs also were more effective in the HPV positive than the HPV negative. Give me 1 second. Sorry, the joys of working in your office. So those 3 drugs listed there, the JAK inhibitor, CDK inhibitor, and hesperidin, were also more effective. So this really raised our interest in looking at Aurora Kinase Inhibitors in HPV-driven cancers. These are the data presented another way. So on the left, there are the p-values for the different families of drugs. And then on the right is a heat map where the columns are the different cell lines, and then the rows are the different HPV inhibitors. And I threw in here also the non-specific inhibitors like hesperidin. And these are the AOC values. So when you see kind of the dark indigo value, that means the AOC value was 0, and anything lighter than that shows that there was some degree of cell death. And so we can see there's a tendency for the HPV, for these drugs to be much more effective in the HPV-driven cancers. So we also turned it around the other way, and we said, okay, for the Aurora Kinase Inhibitors, what are the mutations that correlate, and what are the protein expression that correlate? So we had RPPA data on all of these cell lines. So RPPA is reverse phase protein array. I think probably many of you are aware of it. It's an antibody-based platform in which you can simultaneously look at about 300 different proteins. It's a quantitative method. And so we said at baseline what protein expression correlates with sensitivity to the Aurora Kinase Inhibitors. And that's this dot plot in A. And here the rows are the different Aurora Kinase Inhibitors, and the columns are the proteins that correlated. And then the color of the dot tells you which direction, whether it's correlating positively or negatively. And then the size of this data point tells you the p-value. So the larger the data point, the lower the p-value. So what you're looking for in general are darkly colored big dots. It's almost like being a dermatologist. So what's striking here, there are a few proteins that correlate, but the really catches your eye is RB. And in fact, we attempted to validate many of these proteins using Western blot. I didn't throw all that data at you. I have slides and slides and slides of Western blot. Most of these did not validate. The exception was RB. So here's just a representative Western blot showing the RB expression in the HPV positive versus negative. And as you would expect, knowing the effect of E7 oncoprotein, RB levels are lower in the HPV positive cells, and they also correlate with sensitivity to Aurora kinase. So this is representative data from the RPPA, and then these plots in D are from our Western blots. And so in our Western blots, we looked at RB, phospho-RB, and then we also looked at P16, which is actually a protein that wasn't on the RPPA. And here you can see that there's each of these data points is one cell line, and you can see in the resistant versus sensitive, there's a striking difference in RB expression. The only mutation that correlated was actually P53, and the P53 mutants were resistant to Aurora kinase inhibitors. And again, this all kind of goes along with the HPV story because, of course, P53 mutations are rare in HPV, and RB expression is decreased in HPV-driven cancers. So to validate the findings of our drug screen, we looked at apoptosis, and the tunnel assays shown here on the left. So these are HPV-positive cancer cells treated with the Aurora kinase inhibitor berrazertib, which is a Aurora B inhibitor, and then alisertib, which is an Aurora A inhibitor. And you can see that you do get apoptosis in the HPV-positive cells, but not in the HPV-negative cells. And we also looked at apoptosis using cleaved PARP and cleaved caspase. And I'm just showing the HPV-positive cells here, where we get some very nice apoptosis at relatively low and specific drug doses of the Aurora B and Aurora A inhibitors. And then we didn't see that degree of apoptosis in the HPV negative. We also see apoptosis in vivo. The experiment here in the right lower corner is an HPV positive PDX model. And we can see that over time you have decreased tumor size with, this is a pan-Aurora inhibitor, danersertib. And we do see apoptosis as measured by cleaved caspase in the HPV positive PDX model, oropharynx PDX model. Thinking that RB might be part of this mechanism, we took HPV negative cell lines which were resistant to Aurora kinase inhibitors, and we knocked down RB using shRNA. So these are two different HPV negative cell lines with 3 different shRNA. And so you can see that we do get good knockdown of RB with the shRNA. When with the control SH, the Aurora kinase inhibitor does not lead to significant apoptosis by cleaved PARP. There is a small degree of apoptosis by cleaved caspase, but that's enhanced significantly when RB is knocked down in both the HN31 cells and also in UMSCC4, suggesting that RB is important for this mechanism. Our preliminary data with going the other way, which is to overexpress RB in the HPV positive cells, is also similar, although the data is kind of preliminary, not polished enough to really show in a presentation. So our findings actually go along with 2 papers that were published in Cancer Discovery last year. These papers did not look at all at HPV-driven cancers, but they did show that RB deficient cancers, largely small cell lung cancer and others, were sensitive to a specific Aurora B kinase inhibitor in one of the papers and a specific Aurora A kinase inhibitor in the other paper. And the proposed mechanism is shown here, and that is that when cells lack RB, they depend on the spindle assembly checkpoint to survive. And when that's perturbed by inhibiting Aurora kinase, the cells undergo mitotic arrest and apoptosis. And our HPV model seems to be fitting that as well. We also, knowing the importance of the tumor microenvironment and the immune system, we also looked at the effect on the immune system and looked for immunogenic cell death. And these data in 2 HPV positive cell lines treated with alisertib showed that not only do we get apoptosis, but we also get engagement of the STING pathway, suggesting immunogenic cell death. This is an in vitro experiment where we show activation of the cGAS STING pathway, as well as increased expression of CXCL10 and CCL5. There is a publication in a breast cancer model using the Aurora Kinase A inhibitor alisertib, and obviously don't have time to go through this whole, it's a beautiful paper, but what they showed here is that they actually got more cell death in the MDSC population in their breast cancer model. And so when they combined alisertib with anti-PD-1, they got an additive effect. So that's panel D, looking at the tumor volume. So the combination of the alisertib and the anti-PD-1 is here. You can see it has a significant effect on tumor size, and survival of the mice is best with that combination. So with these data in hand, we went ahead and designed this clinical trial that is now open and enrolling well, in which we're combining alisertib and pembrolizumab, pembrolizumab being the anti-PD-1 antibody. And we're currently in the phase 1 safety cohort, which is going well. When that's completed, we will open the trial up just for HPV positive head and neck cancer or RB deficient head and neck cancer, so we can check RB expression by immunohistochemistry. The clinical portion of this is pretty straightforward. It's a Simon's two-stage design, looking at efficacy as the primary endpoint, combining these two drugs. And then we have a number of different correlates. So at baseline, we will look for things that we think predict expression to either Aurora Kinase inhibitors or pembrolizumab. So for the Aurora Kinase inhibitors, things like RB, MYC, and the pharmacodynamic phosphohistone H3, NPM2, and then of course PD-L1, because we know that correlates with a response to pembrolizumab. We can also gauge the immune response of the patients by using ELISpot assays and E6, E7 tetramers. And we do this with blood and then paired tumor biopsies. So another important effort in our lab that actually was born from a drug screen was one that my postdoc started a few years back, in which she looked at 7 different PI3 kinase inhibitors in about 60 head and neck cancer cell lines. And then she compared the sensitivity of these drugs to mutations. And so what you see on the right, each of these graphs is a different drug, a different PI3 kinase inhibitor. Some of them, like copanlisib, is a pan PI3 kinase inhibitor, and then other drugs like this is omepallisib and bimoralisib are dual PI3 kinase mTOR. Alepisib is more PI3 kinase alpha. So kind of a broad spectrum of drugs in that class. And then for each of these graphs, each data point is a cell line looking at the IC70 values, so a very traditional measure of efficacy. And as you would expect, the PIK3CA mutants are more sensitive than the wild types, but surprising to us was that the Notch mutants were also more sensitive to PI3 kinase inhibitors than the wild types, and this was true of virtually all of the drugs that we looked at. And then the panel on the left is just comparing drug sensitivity to mutation, and again, one of these dot plots where the size of the dot shows you the p-value, and then the color of the dot tells you the direction that it goes in. And so you can see that for the majority of these PI3 kinase inhibitors, there's a positive statistically significant correlation with Notch1. So I'll tell you when my postdoc came to me with this, I said, Notch and PI3 kinase, that doesn't make sense. I don't believe it. So she went ahead and looked at cell death, apoptosis, measured with annexin and BRDU, and with a variety of different drugs. So this is omepallidsib. It's a dual PI3 kinase mTOR inhibitor that was clinically relevant when we started the study many years ago, not so much now. And you can see here that the Notch mutants, which are in red, when they're treated with omepallidsib, we get apoptosis. But with the PIK3CA mutants or the wild type, we don't get apoptosis. We do get cell cycle arrest. I don't have those data here, but we do get cell cycle arrest, particularly in the PI3 kinase mutants, but we don't see cell death. And that's true of the other drugs as well. This is copanlisib and bimoralisib. And again, we're seeing cell death with the Notch mutants, but not with the Notch wild types. So this translates to an effect in vivo in animals as well. So these are two Notch mutant cell lines grown in mice, and you can see a very nice effect on tumor size. And at the end of the treatment period, the cancers had virtually disappeared. These are similar data with copanlisib, which is the drug we're moving to now because it is an IV formulation and it is FDA approved for lymphoma, so it makes it easier to translate. And we also saw responses in patients. So this patient in the upper left panel was a patient of mine who had a Notch1 inactivating mutation, and I managed to get her onto a phase 1 trial that was being run by Philip Yanku at our hospital. And she was the only Notch mutant we got on the trial because it was focusing mostly on PIK3CA mutants. She was a heavily pretreated patient, had gotten all standard treatments, and you can see here that her tumor just disappeared after 2 cycles of bimoralisib. And she actually stayed on trial for about 9-10 months and then actually developed a fistula and died of infection. But really a striking and pretty durable infection for this patient who had gotten all standard care treatment. So we opened a phase 2 trial with bimoralisib, and that was actually proceeding well. But unfortunately, the company that owns bimoralisib did not survive COVID. They went out of business, and so we had to shut the trial down because we didn't have a sponsor anymore. But we did see definitely some signs of activity. The patient here in the lower left was actually our best responder. She, again, had all lines of treatment that are standard for head and neck, and you can see her tumor here in the neck disappear. She had an early partial response, I think a 49% reduction in tumor size that lasted for several months, I think 5 or 6 months she was on. We had 3 patients with stable disease for 3, 5, and 6 months. Again, the 5 and 6 months are fairly impressive given the patient's disease status. This unfortunate woman in the upper right panel, she did have a nice response, which you can see here, although you can also see that this shows us that RECIST criteria are not always the best thing for head and neck cancer. She had a nice response, but she had elevated LFTs, which was an uncommon side effect, and so she had to come off trial, but clearly she did benefit. So we are seeing activity in humans as well. And we are planning a second clinical trial, actually interacting with CTEP now to try to plan that. So I will remind you that Notch mutants in head and neck squamous cell carcinoma are inactivating mutations because many of you who treat leukemia or maybe adenoid cystic are thinking of Notch mutations as activating oncogenes, but Notch can also be a tumor suppressor. And if you look at where the mutations are in the gene in leukemia versus head and neck cancer, you can see they're basically in opposite places. In fact, the leukemia mutations have very well documented and validated as activating mutations. And most of the head and neck mutations are predicted in silico to be inactivating mutations, and several have been validated in the lab to also be loss of function mutations. So it's not obvious I think, to anyone why Notch mutants would be sensitive to PI3 kinase inhibitors. One molecule we found that was important for this was PDK1. So PDK1 we discovered was differentially regulated in the Notch mutants versus the wild types. So here in the upper left panel is a Western blot in Notch wild types with the black text and Notch mutants with the red text, with and without a PI3 kinase inhibitor. And here you can see that in the Notch mutants, you get a decrease in total PDK1. In the Notch wild type, you don't. So there's definitely a differential effect. And then if we take the mutants and we overexpress PDK1, we can actually partially rescue the phenotype. So that's shown in panels D and E. So here the PI3 kinase inhibitor is causing apoptosis, and when we overexpress PDK1, we partially rescue that phenotype using tunnel as a measure, and also using PARP and caspase. We find, as a measure of apoptosis, we find the same thing. So you can see here a partial rescue of the phenotype with overexpression of PDK1. So we are now looking at combinations of PDK1 and PI3 kinase inhibitors. This is a challenge since there aren't a slew of great PDK1 inhibitors out there. I'm afraid I had to block the name of the drug because we have an MTA with the company. But this is a combination of PDK1 inhibitor with copanlisib. And these are very low drug concentrations. So the highest drug concentration, this is, log 10 molar. And so this negative 7.3 is 50 nanomolar. So the highest concentration of copanlisib on this panel is 50 nanomolar. And then the highest concentration of the PDK1 inhibitor is 1 micromolar. And we know that we need around 300 nanomolar of this PDK1 inhibitor to inhibit PDK1. And the upper left panel is fraction affected. So the higher the number, that means the higher fraction affected, or the more effect that you get with the combination. So with very relevant drug concentrations, we're getting a 90% fraction affected. And then if you use the Bliss model to look at synergy in the panel on the lower right, the more bright green it is, the more synergistic, and then the more black or red means additive or antagonistic. So you can see in these relevant drug concentrations, we actually are seeing synergy between the two drugs. So now in the lab, we're looking at cell death and planning in vivo experiments of this combination. So, of course, I would be remiss in talking about head and neck cancer without talking about immunotherapy, because as you're all well aware, there was a big paradigm shift throughout oncology a few years back when immune checkpoint inhibitors actually started working broadly in a number of different cancers, including head and neck cancers. So to kind of set the stage here, these were the first two pivotal studies published looking at checkpoint inhibitors in head and neck cancer, checkpoint 141 on the left and keynote 040 on the right. These were comparing immune checkpoint to standard of care, chemotherapy and cetuximab. We can see very clearly that patients who were treated with the immunotherapy did better. And I think more exciting than just that they had a better overall survival is that there's a hint here that there may be a tail on this curve, and that there may be some patients who have prolonged complete responses, otherwise known as the C word, cure. And so really very important to pursue this. I know this is being done throughout our field, but to try to enhance this, to increase our response rate and to increase the tail on that curve. And then I'll also mention that immunotherapy is approved as frontline therapy for head and neck as well, based on this keynote 048 trial. I can only scratch the surface on keynote 048 because we could talk the whole hour about this, because it's 3 different treatment groups with 3 different biomarker groups based on PD-L1, and so I don't have time to delve into that whole milieu, but just to say that based on these data, immunotherapy is now used as frontline for our patients with improved PFS and survival. So one attempt to improve response to immune checkpoint inhibitors is being pursued by my colleague Bonnie Glisson. This is a trial that she published a couple of years ago where she combined a therapeutic HPV peptide vaccine with immune checkpoint inhibitors. And this is a spider plot looking at the patient's responses. And then this is looking at response. These were largely oropharynx patients, although we had a couple patients with anal and cervical because other HPV types other cancers with HPV were allowed on the trial. And you can see very nice responses and very nice, deep, durable responses. I have a couple of these patients who even a couple years later are doing well. So we did see some nice durable responses. And she actually compared her response to published papers. So this is her nivolumab plus ISA 101, which is the peptide vaccine to HPV. And you can see that response rates doubled. And the median survival time also doubled with this trial. But of course, this is a small single agent or single institution phase 2 trial. And we all know the limitations of those types of trials. So Bonnie has opened up a randomized trial. It's actually opened at several different sites. And I'm sorry, I'm negligent. I don't know if it's open at Emory. I should have looked that up. But this trial is randomized. So half the people get anti-PD-1 with cemiplimab, and half the people get the peptide vaccine with cemiplimab. The trial is accruing well. I have a couple patients on this trial who are actually doing phenomenally well. So just to summarize, our current therapy for locally advanced head and neck cancer has not changed in decades. Anti-PD-1 immunotherapy is effective in recurrent and metastatic head and neck squamous cell carcinoma. Looking at our field as a whole, immunotherapy is being tested in all stages of head and neck cancers. So it's being tested neoadjuvant, adjuvant, concurrent. Those trials are ongoing. Some of the early data from those trials have been presented at various meetings, and they look really very promising. There are many strategies for improving immunotherapy that are ongoing. So I showed you some data from the HPV peptide therapeutic vaccines. There's also additional research ongoing at our institution and others trying to improve those vaccines. There are other checkpoint inhibitors hitting other checkpoints. There are T-cell-based therapies, and there are fusion proteins and others. Right now, the only biomarker we have that affects our standard of care is PD-L1. And PD-L1 in head and neck cancer, like many other solid tumors, is a flawed biomarker. It certainly does correlate with response, but it's certainly not a perfect biomarker. It has its limitations. So right now we have no biomarker-driven targeted therapies for head and neck cancer due to the genomic landscape being dominated by the loss of tumor suppressors rather than by activated oncogenes. One exception here is HRAS, and again, we do expect that tipifarnib will become a standard of care at some point for HRAS-driven head and neck cancer. Also, the hope is that Aurora Kinase Inhibitors at some point become a standard of care for HPV-positive cancers in combination with PD-1, probably through the mechanism of RB loss. But that trial, as I told you, is open and ongoing, so we'll know that answer within a year or so. We do have good data that PI3 kinase inhibitors lead to cell death in Notch mutant head and neck cancer, probably through differential regulation of PDK1. And we do expect to have another trial open for that group of patients in the near future. And the conclusion for our field, I do think that head and neck cancers are poised for large shifts in our current clinical practices after decades of no change. I do think that immunotherapy will be incorporated into therapy, into all levels of therapy. I think that we will be incorporating immunotherapy to locally advanced disease and adjuvant. We are on the verge of having biomarker-selected targeted therapies. And a lot of these new immunotherapy approaches are very promising. Early data look good. And so I do think we're going to move beyond immune checkpoint therapy in the near future. So thank you for your attention, and I look forward to your questions.
Faye, thank you for this excellent talk and review of the exciting field. It really shows how exciting head and neck cancer has become with the immunotherapy first, and now with the data that you presented. I'm not going to ask you about immunotherapy, but even though the field appears to be very promising with what you presented. However, I want to ask you a couple of questions on one comment you made earlier about cell lines and their validity in predicting clinical benefit. And it seems from your work that basically your cell line work has really been very, very productive and very useful. Can you comment a little bit on that? And then my second question is, how do you think these findings that you presented, how have they affected your day-to-day clinical practice when you see patients and you do, for example, genomic analysis on a patient?
Yeah, I mean, the cell line question is very interesting because a lot of people will cite, a lot of clinical trials that were based on cell line data, and those trials failed. But I would argue that every really effective targeted therapy or therapy that's directed at killing the cancer cell, when you look in vitro, you actually can mirror those effects. So, if you look at all the targeted therapies that are approved, like, ABL inhibitors for BCR-ABL-driven leukemia, EGFR inhibitors for EGFR-driven head and lung cancer, all of those have striking effects in vitro. And so I think that people were just looking at the in vitro data the wrong way. So a lot of times people use, whopping drug concentrations that aren't achievable and aren't relevant. That's one big mistake I see made a lot. And then people really are looking at changes in proliferation. And as you know, we don't want to just inhibit proliferation. We want to kill cancer cells. So I think in vitro, if you're a lot more meticulous, a lot pickier about what you call a success in vitro, then those data can be very useful and can actually lead to new and better therapies. And then your question about the genomics, it is our practice here, and I think at a lot of places, probably at Emory as well, that for head and neck patients, when they develop recurrent or metastatic disease, we actually send next generation sequencing at that time. And so that data can be kind of cooking while you go ahead and give a standard of care therapy or enroll them on a trial. And so by the time they progress on that standard of care therapy, you have that genomic data in order to help guide therapy. So that's not, as you know, guiding standard of care therapy, but there are a lot of clinical trials open that are mutation based. And so we've actually gotten a lot of mileage out of that next generation sequencing.
Great, thank you so much. As expected, there's a number of questions from the audience. Dr. Dong Shin is asking about HRAS mutation and making the comment that this is, even though it's rare, it is higher in betel nut chewers and buccal cancer. Therefore, we can look at those particular patients to screen for tipifarnib trials. And I don't know if you want to comment on this, but I do.
Oh, excellent point. And hi, I wish I could be seeing you in person. Yeah, so absolutely. And so also an argument for doing next generation sequencing, I would say on all of our patients, but particularly for the HPV negative patients to find the HRAS mutations.
Thank you. And another question from Dr. Taufeeq Owonikoko. Do you think the loss of RB alone is sufficient for Aurora kinase inhibitor efficacy? Apparently, there is small cell lung cancer data where RB inactivation is very common, but overexpression of MYC appeared to be predictive biomarker. Have you looked at MYC in your model?
So we did look at MYC because there are several publications where MYC predicts response to Aurora kinase, particularly in small cell. And in our head and neck models, MYC expression, either if you look at RNA or protein, did not predict response in the head and neck model. And actually, if you look at those cancer discovery papers, I forgot which one does this, but one of those papers actually looks specifically at MYC because of that literature linking MYC expression to sensitivity to Aurora kinase. So one of those papers delves into that, and there is a correlation, but they found that the RB was a better predictor of response to Aurora kinase inhibitors than MYC.
Thank you. Another question from Dr. Shin. What is the mechanism of additive or synergistic effects of Aurora kinase inhibitors plus PD-1 inhibitors? And nice to see it move to clinical trials. So is there any, I mean, I think with every immunotherapeutic combination, there is a taken that this is possibly going to benefit, but is there any insight as far as what could this interaction be?
Yeah, two potential mechanisms. We are seeing immunogenic cell death with the Aurora kinase inhibitors and engagement of the CGAS STING pathway. So that is one potential mechanism. And then there's this breast cancer paper where they're finding that Aurora kinase inhibitors are selectively leading to apoptosis in MDSC cells, more so than the effector T cells. And we are actually finding something similar in our mouse models as well, although the data aren't mature enough to really show in seminar. But so we think there's a selective effect of Aurora kinase on MDSC. Now, why that happens, no one knows. And that breast cancer paper from Cancer Research hints that there's a differential effect on the STAT pathway. In the MDSC population, but then why you would have a differential effect on the STAT pathway in the MDSC population, that's not known. So a lot of unknowns, but certainly good preclinical data to support that combination.
And this is now moving into an HPV specific trial, correct?
Yeah, we're completing the phase 1 now, which is going well. Hopefully in the last cohort right now. If all goes well, and so we should be able to open the phase 2 within the next couple of months.
Great. Another question from our radiation oncologist, Dr. Mohammed Khan, is asking, where do you see radiotherapy and anti-PD-L1 combo and or neoadjuvant approaches going for head and neck cancer? I think this is a very broad question, but do you want to comment on that?
Yeah, it's one of those, as you know, it's exciting. There's a lot of data, a lot of trials, kind of hard to sort out what the final outcome there is going to be. Certainly, there have been trials using neoadjuvant immunotherapy approaches with phenomenal responses, either before radiation or before surgery. So need to sort out whether that leads to increased survival. There's only one trial that I'm aware of in head and neck where they looked at an abscopal effect and did not find one. I think that was published in it was presented at ASCO a couple years back, and I think it came out. McBride is the author. Yeah.
Correct. I can't remember the journal either, but it was unfortunately a negative trial. Yeah.
Yeah. Very well done. Very well done. Randomized trial. But one trial, so I wouldn't bury abscopal yet. I think it needs to be repeated. Sure. But yeah, but very exciting with I think neoadjuvant treatment is coming back, right? Induction kind of died because of a lack of survival benefit with chemotherapy, but I think with immunotherapy or maybe chemoimmunotherapy, we may see a revision of neoadjuvant induction therapy. In fact, my colleague Renata Ferrarotto has a trial ongoing right now for larynx cancer, in which she's treating patients with a combination of chemo and immunotherapy. And when those patients have a complete response, we actually then observe them, and they don't get surgery and they don't get radiation, which is a little scary. But so far, those patients have been done well, and we're just watching them like hawks, and hopefully get away with, sparing them the toxicities of those other therapies.
Following on the heels of the TPF experience, I think at MD Anderson years back.
Exactly.
Also reminding people that the question of radiation and immunotherapy is a very much a very important question, given the Javelin trial, very recent publication in Lancet, I believe. This is a negative study. So yeah. It really should push everyone to basically look at these interactions. A question from Dr. Georgia Chen. Is there any difference between PI3 kinase mutations and wild type head neck cancer and Notch mutation in response to PI3 kinase inhibitors? So I think the question is, the way I understand it is basically in Notch mutated patients, do you see a difference in response between the Notch only mutated versus Notch and PI3 kinase mutated? That's how I understand the question, I believe.
Yeah, excellent question. So in our cell lines, we only had 2 cell lines that were double mutant. And both of those cell lines were actually quite sensitive to the PI3 kinase inhibitors. But I hesitate to draw a conclusion from 2 cell lines.
So Faye, can I follow on this and ask if your patient who responded or the couple of patients, were they PI3K negative as far as mutations?
They were wild type, yeah. They were not mutant, but PI3 kinase wild type.
Very interesting. Any other questions? I think we're at the end of the hour here, but this was really a fascinating talk, Faye. I mean, I think this is really a proof and a very nice illustration of where the field is heading. And I really thank you for taking the time to do this in a very early time in Houston. And so thank you very much. I remind the attendees that next week there will be no grand rounds. And to review the upcoming Winship Grand Round lectures, you can visit the webpage on the Winship Cancer Center. And I think we'll adjourn and hope to see you in person very soon.
Excellent. I hope to see you guys as well.